Now let's get to what we've all been waiting for, Dr. Brite Hillis' presentation on leadership and innovation in medical education. Dr. Kathleen Brite Hillis is a dedicated educator, precepting at the bedside and remaining involved in undergraduate medical education curriculum for over a decade. Currently, she is the interim senior associate dean for undergraduate medical education and the associate dean for clinical and competency-based education at the University of Arizona College of Medicine, Phoenix. Dr. Brite is a family medicine physician, and she has dedicated her career to serving underserved urban populations. She has been active in community medicine through clinical work at Wesley Community and Health Center and Bayless Integrated Healthcare, where she recently served as Vice President of Primary Care. As the previous chair of the curriculum committee, she remains involved and is passionate about competency-based longitudinal education, time variable progression, and personalization of medical education. Dr. Brite Hillis is dedicated to anti-racism transformation in medical education and works to address health disparities and inequities in medicine. She's a strong advocate for inclusive excellence and increasing diversity in both undergraduate and graduate medical education. Dr. Brite Hillis, on behalf of ArMA, thank you so much for taking the time to join us tonight. Without further ado, please take it away.
Thank you, Juliana and Shelby and Dr. Hartmark-Hill. It's really a pleasure to be here. I hope, can I just get a thumbs up from you that the slideshow is, can you see it okay? Excellent, thank you. It's just a privilege to be here. I'm excited to come and talk with this group today about leadership and innovation in medical education. And I thought I would just start with a quote, a moment of camaraderie. I feel like as physicians, we know this, but this is one of my favorite Helen Keller quotes. We really can do so much together. I think, you know, what we do for our patients and our communities, and when we live together and with our healthcare teams, we know this. I think it's never been more clear than what we've been able to do throughout this pandemic, as we have still found ways to sort of connect with our patients, our communities, provide care, and just carry on. You know, so just a moment of gratitude for all. And then I'll just jump in, starting with a little more introduction, a little more of my personal journey. So I actually had a different journey. I know we actually all have. So I wasn't one that kind of knew I wanted to be a doctor from a very early age. I was the first physician in my family, and I had a single mom who's a teacher. And so when I started my undergraduate medical, or sorry, when I started going to college, I was thinking, oh, I'm going to be a teacher. I was math secondary ed. And I realized as I started volunteering at Flagstaff Medical Center when I was at NAU, that a doctor is a teacher. And it started to progress that way when I realized I wanted to get into medicine and pursue a career in medicine and become a doctor. So I went to medical school at the University of Arizona College of Medicine in Tucson. And the reason why I have all of our ABOR, Arizona Board of Regents public institutions on this slide is because I did 2 years of my undergrad at NAU and 2 years at ASU. And then I did my medical school journey at the College of Medicine in Tucson at U of A. So I've really tried all of our ABOR options. And so that was kind of my journey throughout undergraduate medical education. I did my residency at Banner University Medical Center in family medicine. What I love about primary care and family medicine is how much we get to do and see, but also that continuity over the lifespan. And thank goodness we're all different in what we liked, but that continuity was a really big piece of my decision. And I still really love that aspect of family medicine. So I think I've always known and always gravitated towards teaching. So even as a, you know, again, I started math secondary ed and really loved teaching as a resident, teaching junior residents as a chief resident. And within the second year of my journey as a physician at Wesley Community Health Center, I started taking on medical students and really loved teaching at the bedside and residents as well. So, you know, it's just sort of something that I'm passionate about and have always just really enjoyed. So after I started teaching at the bedside, that was in 2009, I'm going to date myself a little, but I became the clerkship director at the University of Arizona College of Medicine, Phoenix for family medicine program in 2011. And this sort of continuing on my medical education leadership journey, I became the chair of the curriculum committee, really starting to see the curriculum, not just from a clinical lens, but years 1 through 4. and then became the Associate Dean of Clinical and Competency-Based Education. So currently, like Juliana said, I'm serving as the interim dean, senior associate dean of undergraduate medical education and academic affairs here at the College of Medicine. And I wanted to just give a really huge shout out to Dr. ArMA Hill, who is taking on my role as Associate Dean of Clinical Competency Interim to kind of keep things going along with Dr. Laura Mercer as we look forward to hiring a new Senior Associate Dean here at the College of Medicine. So a big token of appreciation. I'm really passionate about many of the things that Juliana said, but specifically competency-based education and innovation in undergraduate medical education. So we're going to talk a little bit about that today. Health equity, inclusive excellence, we talked about that, are all things that I'm passionate about as well. So we'll spend some time. A few fun facts before we jump in that weren't on my bio. I ended up going to U of A College of Medicine in Tucson, and Dr. ArMA Hill and I were in the same class. So we've known each other for a long time. So we share that. I also had a baby in med school and a baby in residency and a baby in practice. So I feel like when residents and med students come and chat with me about that journey, I've kind of tried it all, so we can kind of shed a little light on that for our students too. And let's see, I'll do one more. Oh, I have two dogs, one 80-pound lab named Daisy and a little 8-pounder that adopted me during the pandemic. He's thoroughly bred little mutt named Bernie. So just a few personal things before we jump into the specifics of my medical education and my journey to leadership in medical education. I've learned a lot along the way. And you know, as I reflect, there's lots of things I probably would do differently, but it's all part of learning. So just some of my pearls that I'll share. Mentorship is really important, and seeking that out, you know, is just really important. A lot of times I feel like, oh man, you know, I really want to ask this person to be my mentor, but I'm just not sure if they have the time. They're so busy. But I have found that when I do seek out mentorship from someone who I really want to emulate or learn from, they're always really receptive to that. And I feel the same way as I mentor junior faculty and colleagues. So, you know, not being afraid to ask, and then but it's something we appreciate so much. I think we can all think of our mentors in our lifetime. And so seeking help, asking questions, and then also saying yes to the things that seem a little daunting and intimidating. Maybe I can't do it, because usually they become some of the most rewarding aspects of your career when you take that leap into something you're passionate about that might even seem a little bit intimidating at first when you're thinking about it. And then I put imposter syndrome on here because, and I'll be vulnerable, it's something that I struggle with, and I have my entire career, just thinking, even when I get a promotion or a position, just who me, like, oh man, they can't mean me. And so we're trying to push that aside as much as possible. I'm excited to say that we have that in our curriculum now for our students. We start trying to address imposter syndrome early, like year one, just to help them understand, like, you're here because you're extraordinary, and if you are passionate about something, you go for it, and kind of push back against that. But unfortunately, it's something that many of us, I think, struggle with in all walks of life, but even in leadership positions as well. And then staying involved in professional organizations, just an example of that. It's just a great way to stay connected. I'm part of the LEAD AAMC fellowship right now for leaders in academic medicine. And in my cohort, I realized, oh my gosh, two other of my cohort colleagues are dealing with similar things in student mistreatment and trying to understand, like, hey, we're really good at reacting to things when a student has a professionalism issue or is mistreated at a clinical site, but we haven't really taken it to that proactive step to understand, like, how can we really get ahead of it, identify risk before an event occurs with a learner. So turns out a couple of my colleagues are at the same exact space. And so we're doing research together and projects together, and one's at UCLA and one's at UT. So I can't even stress enough how important it is to sort of network and stay involved in those organizations and have a national option for growth. And then, of course, giving back and being accountable as you're along the way, because we do make mistakes, and that's just part of life. So I think it's clear, and I've mentioned this, but I'm really passionate about medical education. I find it really personally intrinsically rewarding. I love teaching at the bedside. And then for me, I also like the piece of being involved in undergraduate medical education, curricular design, innovative curricular design to kind of meet the needs of our learners today and our workforce needs. in strategizing that future of medical education. And then I'm passionate about faculty education. And Dr. Brite Hillis, our very own Dr. Brite Hillis, our leader at the College of Medicine in Phoenix for faculty development. And it's really, it's something invigorating for me is to help think about how to provide that education for our faculty. But we can talk about it more, I think, when we open the panel up more for discussion. But there's lots of studies, there's lots of evidence supporting kind of the intrinsic reward that I feel, and I hope many of you who are involved in teaching feel too. And I think that's why we do it. But looking at the evidence, there are many studies with very similar conclusions and results, just showing that it's rewarding in the following way: intellectual stimulation. So I can't tell you how many times a student has been the first to sort of tell me about a new guideline before I've even had a chance to sort of see it on Dynamed or Essential Evidence Plus. And it's really nice. I feel like it keeps me current, up-to-date, evidence-based. I also agree with the second bullet, continuing the tradition of medical teaching. I think all of us could reflect on the preceptors and mentors that influenced us and impacted us in the most meaningful ways as we were developing into the doctors that we are today. And then there's that intrinsic satisfaction. Obviously, there's some challenges too that you'll find in studies, but always the studies seem to show that the rewards outweigh some of the challenges. But the themes of challenges would be, 40% or so across the studies of preceptors wish that there was some reimbursement for teaching med students, or more reimbursement for what we're doing. And then there is a workload associated with it. So slight decrease in productivity can be mentioned as a potential issue with taking on more from an academic medicine standpoint and teaching standpoint. And then the workload, we have to do assessments, and some of that's been listed as a barrier. So what do the patients think? The good news is patients like it too. So we have lots of studies showing that medical student participation in care had little effect on patient satisfaction, so that shouldn't be a barrier. And then also studies show that students can be successfully integrated in clinical settings and maintain patient satisfaction and quality as well. There's studies on both. And most patients view medical student involvement in their care positively. And we did a lot of independent studies at Wesley Wesley Community Health Center that showed similar themes. Patients actually really enjoyed being with students, as long as they still saw their provider as well. And actually, they really liked being part of the medical education journey. Like, they felt like, hey, I was sort of a teacher today. I was part of developing this future physician. And they found it to be quite gratifying as well. Obviously, the things that show up in these studies most are, they like being involved, but they prefer to be asked. Sometimes it's just not a good day. They might say, you know what? Usually I'm good with it, but I just want to see Dr. Brite today. And that's all fine. So really just getting permission and making sure that they're in the loop when you're working with students. I think, I'm passionate, obviously, about medical education. And I think one of the things that I really enjoy about my job is getting to understand what our state needs. We want to meet the needs of Arizona and beyond, but really thinking about, like, where are we right now in the state of Arizona? And unfortunately, we have a lot of need for physicians. So I think everybody knows this isn't new data, but we have critical physician shortages in our state, particularly in primary care, general surgery, women's health, and psychiatry. And then I'm going to go over some Robert Graham Center data, just really quickly, to sort of get the state of the state and why it's important for us in medical education and in leadership roles there to keep advocating for what we need. Arizona really is amongst the worst for primary care shortage. And last time we were the 41st worst, and then we were the 43rd worst. And now I think we're all the way down to like the 47th worst state for primary care shortage. So we're not going in the right direction, unfortunately, right now for our state's needs. Just a couple other data points. To maintain current rates of utilization, we will need an additional 1,941 primary care physicians by 2030, which is a 50% increase in our current state's PCP workforce. And just a couple ratios, we have about 200 more patients per one provider in primary care right now compared to the national average. And then finally, just to put it in a different context, there's about 57 primary care providers per 100,000 people in Arizona, and about 76, so 20 more PCPs per 100,000 in the US as a whole. The reason why I'm bringing this up, and it's not just because I'm a primary care physician, because we know that there's lots of robust data that shows where there is good primary care structure in a community when there's a good amount of primary care physicians, that quality metrics are improved, and then we're as a referral base for specialists tend to be part of that infrastructure too. So overall, it leads to a healthier population when we have adequate primary care physicians. So looking at Graham Center data is kind of a reflection of about healthcare as a whole in regions. And then I think it's important to talk about the ecology of care as well, because that'll help guide us further on in the discussion when we talk about how we're doing, the medical school curriculum, how we're currently training our future physicians in med school. So if you take 1,000 patients, of those patients, about 800 report having symptoms. Only about 217 are going to go visit a physician outpatient office. And a lot of those are going to be primary care physicians, but some of them are going to go to their ambulatory specialists as well. And of those 217 out of 1,000, we're only going to send 8 to the hospital. So if you think about that for a moment, a lot of our undergraduate medical education training is still totally centered around hospitalist and inpatient training, when really about 90% or more of healthcare is happening in the ambulatory world. So we're going to talk a little bit about that as well as we keep discussing some of our ongoing innovations in medical education. Continuing a little bit of the current state, just to talk about the undergraduate medical scene. So we have 6 colleges of medicine here in Arizona. So the College of Medicine, U of A College of Medicine here in Phoenix is a class size of 120. Yay, that's an increase in 50%. The College of Medicine, U of A College of Medicine in Tucson is at 120, which increased from when I was there. It was 100. I'm trying to remember exactly when, but that's a 25% increase. We have AT Still, which has 160 students per class. Mayo is here now, they have a class size of 50. And then Midwestern University, Arizona College of Osteopathic Medicine has a class size of 250. And Creighton is here. And the good news here is they're a 4-year college now with 120 is going to be ultimately their class size. And so previously Creighton was only a 3rd and 4th year rotation option. And unfortunately, what we know from studies is kind of immerse a little longer in a community to want to stay. And the fact that it's 4-year now, if that means we have even more learners that are deciding to try to stay here for residency and beyond, that's good news for Arizona. So it's nice to see increases in class sizes in general for our undergraduate medical education. We also have our eye on what's where are our biggest areas of need. And we know that's in primary care, women's health, psychiatry, and general surgery, like we talked about. So we have Arizona Medical School Loan Program back. They haven't awarded loan forgiveness since 2008. So it's really cool to see them back in the scene and really realizing we need to mobilize some funds for students to kind of pipeline them into these areas of need. We still have state loan repayment options, National Health Service Corps. That's what I did personally when I was in school and to pay off my loans on the other side. And then we have increasing scholarship funding too for students that are pursuing some of those areas of biggest need. And I think that's really important. And part of my leadership role is getting to be a part of those discussions and be at the table and advocate for legislative funding and the things we need to continue expanding our class sizes to meet the needs. Arizona's growing. Our population has been exploding, as you know, for a long time, and we really need to meet the needs of our state. The other piece of the learners over the continuum, of course, is graduate medical education. So as we reflect upon, so we talked about UME expansion, we need GME expansion as well. We've seen some good expansion over the past several years, and we're going to talk about that, but I've just listed current GME programs. These are just residencies, not fellowships, but first I started with the UA Banner University Phoenix. Here's UA Banner University Tucson, a list of programs. And it's more established in Tucson. So it's, there's more programs. There's a second page there. And then we have the Creighton Valley Weiss St. Joseph's programs. Again, just residencies, not fellowships for these. Here's a list of our Mayo residency programs. And as I'm looking, I noticed one fellowship stayed on there in endourology. So sorry, these are really just trying to focus on residencies here. We've had some Honor Health expansion, which we'll talk about. And these are the 4 residency programs available at Honor Health. When I was a U of A medical student, they were an unopposed family medicine residency. So then they had internal medicine join as well. And now we have 4 residency programs at Honor Health. And Abrazo has been growing too. Again, when I was a medical student at U of A, they just had a family medicine unopposed program. And you can see now that they're growing across many different disciplines. We've also had growth in the rural health scene. So we have a family medicine program in Yuma. We have another North Country family medicine program in Flagstaff. So lots of exciting expansion, and this is critical. We know that learners have an even higher likelihood of staying where they do residency. If you reflect upon residency, that's where you're getting recruited in your last year of residency. A lot of us are signing contracts before we're even finished. So the idea that we can expand GME to accommodate and have soft landing spots for our Arizona UME students is really exciting. And it's all made possible because of Congress passing a historic increase to the Medicare graduate medical education program in 2021. And so that was the first time, just to put it in perspective, we had a little bit of a stalemate. Like we were really not having GME growth to match the UME growth at all because we didn't have funding. That was the first time Congress allocated more funds in 25 years. So it's nice that that happened, and we have lots of exciting things on the horizon. So Dignity's slated to continue expanding into the East Valley at Mercy, Gilbert, and Chandler Regional into internal medicine, family surgery, OBGYN, and emergency medicine. We have more expansion at UA Banner University Medical Center and Banner Medical Group in Phoenix. Expansion both in the existing programs, and I was reflecting my class size at Banner University was 8. I think it's been 8 forever. So expanding existing programs, but also looking to expand and add new programs as well, such as emergency medicine, dermatology, ophthalmology are all programs being discussed. Honor Health has added 9 programs in 5 years. So I showed you guys the residencies, they have fellowships as well, and there are still more to come. And then we have really cool rural health opportunities. So Payson is looking to, there are one of our LIC clerkship sites for the College of Medicine Phoenix. They're looking to expand to have a med-peds program as well as a family medicine program. Cobra Valley would like family medicine. So Yuma and San Luis is excited about getting GME going. So we have lots of really exciting GME on the horizon for the state of Arizona. So that's part of in medical education leadership, part of what I get to be a part of, advocating and trying to understand and help meet the needs of our state. And then let's talk about the curriculum really in general, just looking at the undergraduate medical education model. It's kind of been the same. So as we reflect upon our journeys, nationwide, it's pretty similar to how we remember our medical education journeys. It's a 4-year curriculum, pretty much across the nation. That's what you're going to see most standard. The first 2 years at most programs are now pass-fail. And the years 3 and 4 have remained to the tune of about 85% tiered. So honors, high pass, pass-fail. So very kind of high stakes, still summative based, where a learner is kind of going through a whole clerkship and they get this really high stakes end of the rotation summative final grade based on their performance. And I think it's become a lot more stressful for our students since we were in training because of the pass-fail first and second year. You feel like, oh my goodness, years 3 and 4, my clerkship and are the only time I can really stand out. And I think that's felt even more acutely for some of our students now that the step 1 is pass-fail. So it's an interesting situation. And on average, we see grade inflation as a result because we know it's high stakes. And so when we look at our dean's letters, and we have a really high amount of honors and high pass in all of our clerkships, and this is nationwide data. And then also our dean's letters paint everyone in these really positive lights. And as a result, the program directors and the programs are sort of thinking, gosh, I better do more interviews because, I'm not really getting as much information, meaningful information as I would like from these letters and from just the portrait of these students. And so it's not uncommon for programs to be interviewing up to 1,000 different medical student applicants, and for our students now to be interviewing at 70, 80, 90 different programs. So it has definitely sort of changed into an area that's stressful, I think, on both sides, both for our learners in the UME world and for our programs. And certainly we talk about this a lot at our medical education senior leadership forums with the AAMC of how can we we probably need some reform, and what would that look like? Because it's certainly a very stressful situation right now for all of our UME and GME colleagues alike. Also, clerkships have been blocked, I think probably forever, for the most part, where we do, 6 weeks in family medicine and 6 weeks in psychiatry and kind of going along like that. And that's kind of been the third year curriculum. And there's been very little personalization until fourth year. But you might recall students are asked to sort of pick their fourth year midway through third year. So they honestly haven't even experienced all of their clerkships yet when they're being asked to think about the next year for scheduling. So we realized, like, hey, this is probably not working as well as it could. And it's really another interesting and amazing part of being in medical education leadership is being able to talk about some curricular initiatives that are innovative and might really end up being best for both learner and preceptor, and ultimately for the match and residency applications in general. So the way that the University of Arizona College of Medicine is doing this is we're focusing on competency-based education. And we've been working on this for several years, kind of rolling out changes. And we're focusing on entrustable professional activities. So GME residencies are competency-based, but UME is not yet. So we're looking at sort of these entrustable professional activities that you can find in the AAMC. There are 13 of them. I like to call them everyday physician activities. So it's sort of like what we would expect all of our learners to be doing, to say, okay, you're competent, you have finished your medical school journey and you're ready to become a resident. So it's kind of like residency readiness assessments, but it requires a different type of an assessment strategy that really includes frequent real-time formative feedback. So none of this like high stakes end of rotation, big old summative piece, but as you're going, giving ongoing feedback to the student, because really, we all have certain strengths and we're all working on things. So what am I doing well and how can I get better? And it's done in a very student-centric way and student-driven as well. So they'll be able to kind of see longitudinal development over time as they increase their autonomy and realize, hey, here are my strengths and this is what I'm working on. We do this with dashboarding and lots of pixels and information and data points for the student. So let's just take one of the EPAs, is gathering a history and physical exam. So if they have a few really straightforward patients that are just there for maybe URI type symptoms and don't have other issues, they might be here, wow, but then they might have a really complicated patient who has early dementia and polypharmacy, then they're gonna, so students, improve over time like this, but they can watch their progress as they're growing across all of these EPAs to understand where they need to focus their time and work with their preceptors to understand, like, here's what I'm doing well, and can you help me with this? I liken it to lots of different pixels, little data points. And so when we zoom out of this picture, it's actually pointillism. It's a Georges Seurat picture. And you can see, like, when we look big picture, it's the profile of a male. But essentially, this is what we're doing. The pixels kind of are across all of these different competencies, but ultimately we're creating the portrait of a learner who has successfully demonstrated competency across all of these 13 EPAs. Therefore, they've demonstrated residency readiness. And we can say confidently to these programs, like, they've met these expectations and they're competent and ready for the next phase of their journey. So it is really different and exciting, but this graph or this chart just kind of puts side by side traditional medical education with competency-based medical education. So you can see traditionally, and where we're kind of still stuck, is we're subject-centered as opposed to learner-centered. In traditional medical education, we're emphasizing time-based learning. We have first year, second year, third year, fourth year, no matter what, everyone's kind of in the same trajectory, right? Whereas competency-based medical education de-emphasizes time-based learning, and that's what we call time variable. So if you can imagine, instead of saying first year, second year, third year, fourth year, you might say, hey, you're in your pre-clerkship phase, you have now demonstrated competency, you phased into your clerkship phase, now you're phasing into career exploratory phase, and then finally you're phasing into sort of like a residency readiness phase, boot camps, advanced electives in your specific specialty, just to sort of get yourself really prepared for that next stage. And you know what, it might happen at you might phase at different times. So that's why we say it might take 4 years, and that's great if it does. Some students might know coming in that they want to go into, say, let's just pick pediatrics. They might stay peds the whole time. They might demonstrate competency and even be able to match early and join our workforce earlier through like a 3-year progression strategy. Traditional medical education is focused on summative assessment, like we talked about, where competency-based is formative assessment. There's little opportunity for feedback in our traditional setup, whereas in competency-based, feedback is really the core process of training. Students are seeking it. They're all improving based on their strengths and areas of opportunity, and they're going to be leading that charge to reach competency across their EPAs. Learning focuses on knowledge versus focusing on attitude and skill. And then, right now we're kind of doing these high stakes assessments, and it's the grade, and the grade is everything to the student rather than focusing on assessment that's for a defined desired competency level. So lots of big differences, but really anyone who's precepting can reflect for a moment, and we're kind of teaching in a competency-based way. I mean, I don't think any of us are waiting until the end of a rotation to say, you really need to work on X, Y, or Z. No, we're giving feedback, at least verbally, from day one to help our learners develop. And also, we are getting to know our learners, and they are earning our trust, right? So as we observe them, we are starting to entrust them with more and more responsibilities with our patients as they show us that they can be more autonomous. So we're kind of already doing this implicitly. The competency-based model just helps to make all of this transparent and explicit for the learner so they can guide their development as well. So the way that we're doing this and working towards this at the U of A College of Medicine Phoenix is we're shortening our pre-clerkship time. So they start at the bedside as, in first year, they're doing bedside training as well. And a lot of it's active learning. But essentially what would have been considered first and second year curriculum, we will now be finishing, all of our students will be finishing that pre-clerkship phase by the holiday closure, so in about 1.5 years. And then they're going to have shortened clerkship lengths as well. So we've shortened already our internal medicine and our surgery clerkships have gone from 12 to 8 weeks, and we're shortening our 6-week clerkships in family and psychiatry and OBGYN and pediatrics from 6 to 4 weeks. And we're keeping our students immersed at the bedside during that time. So we have feathered zones, week-long zones for just-in-time learning to get ready for their next clerkships, learn how to don doff before surgery, for example, and also do some of the interactive didactic and sim content before they even embark upon that clerkship. So we don't have to pull them back out of clerkships for didactics. We can keep them kind of immersed. But by doing this, it allows for personalization into areas of interest earlier for our students. So essentially, they'll finish what was traditionally 3 years of curriculum in 2.5, and really be able to say, gosh, I'm torn between, because I loved everything and I was undecided and I needed some more time to sort of deep dive into certain things and realize that family let me kind of put everything together. So that was my journey, but kind of let them deep dive into areas of interest sooner so that they have some time to really decide on their career choice and not have to be rushed into creating a 4th-year schedule before they've even experienced half of their clerkships. Obviously, part of this discussion is that we'll be focused on competency-based and personalized medicine, and it will allow for time variable education. So kind of breaking the mold of everyone's going to kind of develop at the same rate. And of course, eventually, we hope that there are some 3-year progression to residency opportunities. This is happening in pediatrics and other specialties across the nation. It's not common yet, but again, if someone kind of knows and they can demonstrate competency both at the UME and when they audition at their GME level, they can progress sooner than 4 years. It also saves the student a year of financial debt and gets them into our workforce. And we know from the data that we need them in our workforce desperately in our state. So as we do this curricular renewal planning, we try to, this is our Venn diagram that we sort of hold most sacred. We try to consider, we want our changes to be competency-based and personalized, and we always want to keep student wellness at the heart of it too. So that's kind of our sweet spot. And a lot of this, it's new and it's unfolding over time. And so a lot of it is just helping our preceptors understand as well. We don't want to be burdensome. So when we say more frequent feedback, it's very short, handheld, quick dictation, just real time based on that encounter that just happened. Hey, what did the student do well and how could they kind of get to the next level of autonomy? And so a lot of that takes faculty development and thoughtful consideration. So again, I know I said this, but Dr. Brite is our director of faculty education, and she's been really great about helping us design modules and help train our preceptors, so they're kind of getting used to what this means and the why behind it and why it should be rewarding for both the student and for the learner, for the preceptor as well. So I know that's a lot of information, but I think being part of medical education leadership allows us to sort of be in on all of these exciting and innovative things on the horizon. And I will say that we have challenges in all areas of healthcare. We know we have attrition, we have provider and workforce shortages. We're working hard to battle health inequity, social determinants of health. But, you know, medical education has its challenges, as I've illustrated in this. But you know what? We are part of a solution, and the future's bright, and we can really make a difference together. I put this last bullet on here. Just love to hear from you. My email address is on the cover page as well, if you're interested in getting involved or more involved in medical education. And this is not a recruitment for the U of A College of Medicine, I promise. I'm on the KHEC board, which is Arizona Health Education Center for Central Arizona, and it has representation from all colleges of medicine. So if your alma mater is not U of A and you want to connect with, Midwestern, whoever it may be, I can help point you in the right direction. And then additionally, I love interprofessional education. I teach both med students and residents, but also nurse practitioners, DNPs from ASU and podiatry students. So if you're thinking, well, gosh, I like to expand my learners because I want a more immediate pipeline. I don't want to wait till residency. I have workforce needs in my practice now, for example, and you like to connect on that, I'm happy to talk about ways to connect for interprofessional trainees and learners as well. So here are my references, and I'm really looking forward to having some discussion. Thank you all for coming this evening, and again, just for being such an amazing part of our physician workforce.
Dr. Brite Hillis, thank you so much for that enlightening presentation. I knew that the world of academia was very different, but my eyes are wide open now. That's fascinating. I'm sure many of those online tonight have follow-up questions, so we'll get started on the Q&A portion of tonight's webinar. For those of you who are attending, if you have questions for Dr. Brite Hillis, please use the Q&A function at the bottom of the screen to submit your questions. While you work on submitting your questions, I'll be turning over the moderation responsibilities to our devoted president, Dr. ArMA, who will lead tonight's Q&A session with Dr. Brite Hillis. In addition to being ArMA's 131st president, Dr. ArMA is a Mayo Clinic trained family medicine specialist, an alum of the University of Arizona College of Medicine, Tucson, and an award-winning medical educator at the UA College of Medicine, Phoenix. She currently serves in many capacities at UA-Com Phoenix, acting as director of the Faculty Development Fellowship, director of the Program for Narrative Medicine and Health Humanities, and director of the Patient-Centered Care Curriculum. I don't know how you get that all on a business card. Dr. ArMA, thank you for being here with us. The floor is yours.
Well, thank you for that kind introduction, Juliana, and I absolutely agree. So impressive. Dr. Brite's leadership in medical education, patient care, advocacy, and beyond has been truly an inspiration for me. I can say my entire medical education and training, because as she said, we graduated together in the class of 2005, way back when. So it's just been a joy, Dr. Brite Hillis, to see your growth, your leadership, your transformation of medical education. And thank you so much for sharing your wisdom with us tonight. I know we have a number of questions coming into the Q&A, and I'll encourage many more. I'm going to start with a question from Dr. Jameson, who's asking about any national or local research on adverse outcomes of the 3-year progression to residency, and or feedback from any of the residents who felt like this may not have been as successful as they thought it would be.
Yeah, that's a really great question, Dr. Jameson. And I feel like most of the data is around EPAC, which is a pediatric progression. And we have good data showing success. And I think it's successful because there's off ramps because some of us change. I honestly probably would have put money on, I was going to go pediatrics myself when I started, but if something else catches your eye, people change, there's off ramps. And it's also a summative entrustment decision about competency is not just made on the UME side, it's made in collaboration with the GME program where that 3-year progression is coordinating with. So when the UME side says, okay, we think that this student has demonstrated competency and is ready, there's usually a 4 to 6 week overlap time when the graduate medical education program weighs in as well to say, yes, we think they're ready, they're meeting our expectations, or they're part of those summative entrustment committees all along the way, making those decisions together. And I think that's why it's been successful. So I haven't really seen data to the adverse, again, because there are off ramps and other options as well. So yeah, I hope that answers your question, but I always keep combing the evidence for any other things that might help us understand, because we don't want to make any changes that would be detrimental to our students or our programs, obviously, too.
Thank you, Dr. Brite. I really appreciate that answer, and would just double underline what you said, because and I want to emphasize to our listeners too how very different this 3-year progression based on competency entrustment is to what we may have experienced in the past with a time set 3-year program. So we're really excited, and we're looking at the data. We have a lot of future research to do, but we are in good hands because Dr. Brite Hillis and our leadership team is looking at those outcomes. So thank you again for that answer. Dr. Jameson has another excellent question that I'm going to go to. He asked, what do you feel are the biggest challenges of coordination of care between specialists or subspecialists and primary care, and any implications for medical education? Great question.
Yeah, I think care coordination is such an area of learning for our students because it is complex and challenging. And I think we've used technology to try to overcome some of those things as far as, automated EMR-based referrals. So there's no more like, oh my gosh, it got lost on the fax machine and the referral never went through. And I feel like we've made some progress, but getting information back from specialists so we can really coordinate care is still sometimes a challenge on the primary care side. And then I'd love to see the other panelists' thoughts. A lot of my career has been spent at a very underserved, federally qualified health center where about 90% of the patients are uninsured. So I do copals and leaps and vasectomies and casting and splinting, and I really feel like we take care of about 95% of what walks through the door, because just seeing a specialist isn't much of an option for many of the patients that we care for there. So I feel like that's also good for students because they're learning a lot about practicing broad spectrum top of license, but then also about community resources, right? So I can do a copal and I can do a leap, but when someone has cervical cancer, they need to see gyn-onc. So how do I mobilize those resources? And when I've been in private practice, I think the biggest challenges are the ones I mentioned, Dr. Jameson, which is sort of just making sure that the referrals placed adequately, we get information back so we can coordinate care on the primary care side of things as well.
Absolutely. Excellent answer. I appreciate that. And I will just comment that throughout my presidency, I've been spotlighting physicians who are actively integrating screening for and acting upon mobilizing resources for social determinants of health. Mm-hmm. And you're just a true exemplar of that. And I'm so grateful that students are in practice and learning that from you in that coordination of care, but also addressing, those really important factors that make a huge difference in their outcomes. So I want to thank you for that, and just kind of add my own question to that while we're waiting for more questions to come in in terms of addressing the social determinants of health. It's a kind of a newer landscape. We've got a lot of data now to support that it's so crucial in every specialty and every subspecialty where patients are at. And, my question would be, what have you found that's helped you be successful in taking those approaches? Because it's certainly not something that, we had a lot of training in when we came up through, the medical ranks. So how have you pivoted to do that so successfully?
Well, that's a great question, Dr. Hill, and we do a lot of social determinants of health screening as well, which is really nice and helpful. I also feel like having care coordinators and promotores in my practice is really important, because I like to feel like, oh gosh, you know, everyone can relate to me and they feel comfortable. But whenever you add credentials to the end of your name, regardless, you RN, MD, DO, you know, it creates a little bit of a barrier. So having a promotora, a community health worker that really can determine the specific needs of my patients has been really helpful for me too, to talk to them at that level and kind of review the screeners and the SDOH screeners. And then honestly, I've been practicing in an integrated setting with both behavioral health, emotional health, and physical health. And I feel like that makes a huge difference as well, because emotional health is just part of health. And the more we can coordinate that care, I think it's very helpful. Because otherwise those referrals can be very challenging to get to the emotional and behavioral health pieces that the patient needs to even start taking advantage of some of the resources to address some of those social determinants of health challenges that they're having. So I think those things all work really well together.
Thank you. Totally agree. And I want to kind of pivot us back to something you mentioned early in your talk, and that was the power of mentorship throughout the medical education journey, especially into academia, where then you are the mentor for others. So, you know, what you mentioned, you know, not being afraid to ask, what are some other things that have helped you successfully identify mentors, and what would you suggest to maybe some of the medical students, residents, early career physicians who are on the line with us today?
Great question. I think that I've had mentors that I haven't even formally identified as mentors that have been just such amazing influences to me, that have just, you know, seen something or taken me under their wing. And I've realized, oh my goodness, I've had some informal mentorship that has been absolutely pivotal and meaningful for me. And then I've had more formal, you know, seeking out, would you be my mentor? And I think it's just what I talked about, Dr. Hill, which is just asking if you have somebody who you know can help you in certain areas. For me, I have a lot of leadership experience. I took over as the CMO of an FQHC when I was in my early 30s, but I really, you know, didn't have a lot of experience in academic like scholarship and publication. And you know what, we're not born knowing how to publish. So being able to reach out to those contacts who you know can help you in those certain areas that you've identified as areas for growth, I think is important too. And then just not being afraid to ask for it. I always kind of feel like, oh, I don't want to burden someone who's busy. And I feel like I've always or typically been met with very open arms in mentorship. And the few times it hasn't been, it's been super sincere of like, oh my goodness, my dad's card is full, but here's another person I can connect you with. And that's greatly appreciated too.
Absolutely. And that actually makes me fondly reflect on a conversation that I had with Dr. Jackie Chadwick back in the day, who was also the first female president of the Arizona Medical Association in the 90s. And of course, our first vice dean of medical education at the College of Medicine, and, you know, talking to her about mentorship. And I was also relaying, you know, the hesitancy and, you know, worry about her being so busy, you know, in terms of asking her to mentor me. And I just remember she said, you know, Jen, don't worry about it. It's really nice to be asked. And that was so simple and straightforward, but it really stuck with me, because I think that we think that people who could be mentors and teachers and guide us are so busy and so kind of, you know, kind of unapproachable.
Yeah.
But at the same time, they're human beings. And when we do reach out and say, you have a skill set that I really admire, I want to emulate you, that's affirming, I think, to the people who are leaders and who are out there doing the good work. So to anybody who doesn't have a mentor in a particular area, please keep that in mind. Please do reach out. And yes, Dr. Chadwick has mentored many of us. So I want to go back to something that you talked about, and I so appreciate your courage and vulnerability and the way that you shared your journey. You talked about struggling with the imposter syndrome, and that's, I think, common for many of us. Are there ways that you have been able to mitigate that, or are there things that you've, you know, along your journey, you've had to kind of pivot away from because of that? And what would you recommend to anyone who's maybe struggling with similar issues?
Gosh, that's a really good question. And I still think I do struggle with it. I feel like I still have that, oh my gosh, am I ready? Or they can't possibly mean me, you know, and in many of my phases. But I think over time, so I can't really see who all of our participants are, but I think over time, the more you take on, that might have felt intimidating at first, and where you realize like, hey, you know what, this is something I can do. And then it just sort of becomes more of a natural, it's still there, but it's more of a background buzz instead of something that's really going to create a barrier or get into your way. So I think that's helpful. And I think being humbled as we learn, I mean, sometimes you know, you might take on something that deep down you knew wasn't good timing, maybe just you didn't have time for. And, you know, whenever you're feeling like, it's not that I can't do this, but I really can't give this the time or the dedication that it needs. It's also okay to unload that and to be honest with yourself and others around you so that everyone can succeed, which has happened to me a couple of times when I just literally, unless I could figure out a way to not sleep, I just took on a little too much, and I need to sort of prioritize and say, gosh, I need to hand this off. And then I think being humbled by learning experiences, I definitely have had experiences that didn't go well as I planned for them to go. And I've learned from those too. And it helps me make decisions going forward too, as I decide whether or not I want to take on a new challenge.
More sage advice. Thank you for that. Well, our final question that I'll take is again about the time variable progression to third year, which I think our audience has rightly identified as a very big innovation that we have in the future of medical education. So the question is, what percentage of students do you think will be likely to progress in 3 years once this is fully expanded and offered for more specialties? Would you kind of put it in the ballpark of a large majority, 50-50? Very interesting to see how this develops. And I agree.
Yeah, I think we're going to be starting with small numbers actually, because we are creating some curriculum that GME is not necessarily ready for, because what we'll be doing is sort of matching outside of ARIS. So if you can imagine, this is like, hey, if you kind of carve out 2 spots in said residency, as long as we mutually decide they're competent, they'll be kind of doing an outside of ARIS placement. So these things usually start kind of slow. Right now at the U of A College of Medicine in Phoenix, we have several programs that are really interested in this because they know that it will help fill workforce needs. It's very appealing. So we have pediatrics has expressed interest, family medicine has expressed interest, as well as internal medicine. And psychiatry has actually said this would be great for us too. So we have potentially 4 programs, but even if we're thinking of maybe 2 seats in each of those programs, we'll be starting at about 8. Within our UA programs, because this isn't nationwide. It's usually more of a collaboration within your own home programs to get things like this started. So I hope that we can become more and more time variable and have expansion of these models, but it will be starting slow and grow. It'll be starting low and growing slow as we keep evolving.
Well, thank you again, and our gratitude on behalf of the whole ArMA team. Really appreciate the wisdom you've shared, your journey, and the advice. We will take it to heart, and we so appreciate the work that you're doing into the future. I think folks can access Dr. Brite Hillis's email in the chat, and please do feel welcome to reach out. She is one to watch. She is leading the way in medical education and innovation. We're so grateful to you, Dr. Brite Hillis. I'm going to turn things over to Juliana Stanley to wrap us up.
One more time, thank you, Dr. Brite Hillis, for your insight. And to our attendees, thank you for spending time with us this evening. Look forward to seeing you at another ArMA event in the future, and I hope you have a great night. Goodbye.